It is an honor to welcome someone who understands not only the scale and complexity of the problem, but is able to clearly articulate the immense opportunity in front of us. Please join me in welcoming Dr. John Kitzhaber.
Well, thank you. Thank you for that kind introduction. I'm actually pretty excited to be here. Some of you may know I started my career as an emergency room doctor and also my political career just north of here in Roseburg. So coming back to Southern Oregon always feels like coming home, and I really appreciate your invitation. This wasn't what I was going to talk about, but the story that we just saw really moved me. And I remember when I started practicing in the ER, I was 27 years old. I was 4 months out of my internship, and I was terrified. The people were probably terrified as well to have a 27-year-old guy looking over them. What I remember most is how vulnerable the people were who came to see me. They didn't know me. They were hurt. They were afraid. They were looking for help, and they put their trust in me and sometimes their lives in my hands. And it was an enormous responsibility. And I remember once an elderly woman came in, and she had chest pain and shortness of breath, and so I worked her up for a cardiac problem and didn't find anything, sent her home. She comes back the next time I'm on, and when I was charting, we used to actually do charts in those days, she was coming in quite a bit, and she only came in when I was on. And so I told the receptionist, I said, next time she shows up, don't check her in unless she looks like she's dying, and just come and get me. So I took her down to the cafeteria, and we had a cup of coffee and had a talk. And she had a brown bag of medication. She was seeing a cardiologist for atrial fibrillation. She was seeing a rheumatologist for arthritis. She was seeing a urologist for polycystic kidney disease. And she was being viewed and kicked around the system as a kidney, a joint, and a heart. She didn't need access to medical care. She needed access to compassion. She needed access to someone who could make her feel belonging and part of something. She needed someone to talk to her about the maze and help her guide through this and to deal with her pending mortality. She needed access, but it wasn't access to medical care. And I also remember during the recession of the early 1980s, I saw a young woman come into my unemployment. Well, you remember that time, unemployment was about 22%. And she looked like she'd run into something. She had this black bruise with a laceration on it. It wasn't a very serious laceration. I sewed it up and took her down to the cafeteria again, one of my favorite places for, hospital didn't like that very much. And it turned out she'd been hit by her husband, who had worked at Sunset's as his father had and lost his job. And after 6 months, he got sullen and depressed and started drinking and then became abusive and then violent. And I remember seeing more and more people like that come in during that period of time. And it was the human face of poverty. It was the human face when hardworking, proud people can't put food on the table. And I've never forgot that moment. And Alice needed access to medical care. Her husband needed access to a job. They needed access to the security of knowing they could pay for their house and their rent and look after their kids. So I want to talk about access today in sort of a broader sense. Access to medical care is really important, but I want to start. I can figure out how to use the technology up here. By looking at your title here today, Protecting Access to Care, Building Bridges and Breaking Barriers to Vibrant Health. And I'd like to focus on the last two words there, vibrant health, right? I think it's important for us to remember that that's our objective. Our objective is health, not necessarily access to medical care. Medical care is incredibly important, but access alone is not going to produce vibrant health for most Oregonians. Indeed, if healthcare was synonymous with health, we'd have the healthiest nation on the planet. But we don't, right? We have the dubious distinction of having the most expensive healthcare system on the planet, producing some of the most embarrassingly poor health outcomes. That's not due primarily to a lack of access, although that plays a role. It's due largely to the fact that among those things that have the biggest impact on lifetime health status, medical care is a fairly small contributor. Far more important are things like healthy pregnancies and stable families, good nutrition and housing, safe communities, education, economic opportunity. But as the cost of healthcare continues to go up and up and up, not only does it create a rising barrier to access, but it undermines our ability as a society to invest in those social and economic factors that would by far have a greater impact on producing vibrant health for Oregonians. So our central challenge here is, to me, really clear. It's to reduce the total cost of care. That's the elephant in the living room. Not only to reduce the barrier to access to medical care, but also to give us the ability to address these social and economic conditions that are driving people into the acute care medical system in the first place. And it's worth noting that the individual and social benefits of these early investments go far beyond healthcare. Brain science, science of brain development tells us that poor nutrition and stress before conception and during pregnancy alters the genetic expression in the unborn child and can dramatically increase the likelihood of poor cognitive functions and learning disabilities, behavioral health and substance use disorders, risky behaviors, and the adult onset of many, many chronic illnesses from diabetes to cardiovascular disease, right? So putting a priority on these kinds of early investments, carving a space in our public budgets to invest in these things should be of primary importance, not just to patient advocates, but for those who are champions for education and public safety and housing and child welfare as well. So I want to do two things today. I know we have a mixed audience in terms of their literacy in the world of healthcare. So first, I want to try to leave us with a common understanding of how our healthcare system is financed, why it's in crisis, and why simply putting more money into the current business model is not going to lead us to vibrant health. I would argue probably in the opposite direction. Second, and I think more importantly, I want to remind us that we are not powerless here. I don't think we can expect a solution coming out of our nation's capital anytime soon, but that doesn't mean we have to let our healthcare system here in Oregon get swept over the brink of this rapidly approaching fiscal precipice, nor do we need to allow the cost of healthcare to continue to divert resources away from investments in children and families to feed this insatiable appetite of an acute care medical system. And finally, I think it's important for us to remember that the crisis we face today is not simply the result of House Resolution 1, the so-called Big Beautiful Bill, and that was the only time you'll hear me say the word beautiful in connection with this piece of legislation. Before that passed, our healthcare system was in crisis. Hospitals were struggling, physicians' practices were struggling, and our healthcare system was simply on an unsustainable course. So I think it's important as we look for solutions and ways to change this trajectory that we recognize that H.R. 1 accelerated our rush to the precipice. It did not create it. So here's the fundamental problem as I see it. Funding for our healthcare system is based on what I call a fiscal fantasy. In other words, that the escalating cost of care is disconnected from the resources available to pay for it. We could probably say the same thing about our education system, increasingly. Another topic, another luncheon. But consider this for a second. Healthcare is probably the only business sector that produces goods and services that none of its customers can afford. What else works like that? So this only works from an economic standpoint because the health care for individuals is heavily subsidized, increasingly with public resources. So those resources come in two ways: directly through programs like Medicare and Medicaid, or indirectly through the premium subsidies in the ACA individual market, which is the central point of debate of the government shutdown, or through what's called the tax exclusion for employer-sponsored coverage, which allows employers to deduct from both their federal income and payroll taxes the cost of the premiums they buy to ensure that their employees have access to health care. That's about a $350 billion annual subsidy of workplace-based coverage. So the point is that the practice of medicine or running a hospital only works as long as these payers are willing and able to continue to pay these subsidies. But what's happened is the cost of care has continued to go up. Both public and private payers have developed ways to shield themselves from the cost of care, not by reducing it, but by shifting it to somebody else. So today, almost all people in our country depend on some form of public subsidy to cover their health care. If you're on Medicaid, it comes from the state and the federal government. If you're in the ACA individual market, it comes from the federal government. If you have an employment-based policy, it comes from your employer and the government. And if you're on Medicare, of course, it comes from the federal Treasury. So it's really important to recognize the nature of the cost shift. If there's one thing you take away, it should be this slide. So as I said, as the third-party payers are trying to avoid the cost, not control the cost. So if you're a state, you have to operate on a balanced budget. So states are increasingly put in the position of choosing between funding increased healthcare costs or funding an education or housing or economic opportunity, right? And eventually, states shift costs to individuals by changing income eligibility for public programs and dropping people from coverage. That's what's going to happen if nothing changes in Oregon. Probably 200,000 people will lose coverage, not counting the ACA subsidies, just because of the $11 billion we're going to lose over the next decade in federal Medicaid funding. If you're the federal government doesn't have to balance the budget. So for decades, Democrats and Republicans have been pushing their difficult political decisions, including the cost of Medicare and Medicaid and the tax exclusion, into the national debt, which is now $37 trillion. I want to say just one thing about that, because this is a ticking time bomb that's not really part of the everyday discussion. Do you know how much $1 trillion is? Well, when you leave here, get out your calculator, and you will discover that 1 million seconds ago was 11 and a half days ago. 1 billion seconds ago was 1987. 1 trillion seconds ago was 30,000 BC. So the federal strategy here basically is to continue to run up the bill and pay for today's healthcare costs by leaving that bill for our kids and grandchildren to pay for. And I leave it to you to decide whether that's a morally defensible strategy. If you're an employer, you shift costs to your employees by increasing co-payments and deductibles, often to the point that they are, for all practical purposes, uninsured. Those uncompensated costs then are shifted back to the employers through increased premiums. It's also important to note that people that don't have health care coverage don't just disappear, something that Congress didn't think much about, I think, when they passed H.R. 1. What happens when they get sick enough, they go to the emergency room, one of the most expensive care settings where federal laws, one in particular called EMTALA, the Emergency Medical Treatment and Labor Act, requires that hospitals see them. And those uncompensated costs then are shifted back to employers driving this vicious cycle. So the cost shift is a direct response to the total cost of care. And paradoxically, the more money you put into the system, the cost shift drives an ever-increasing number of people who are uninsured or underinsured into your hospital or practices, continuing to erode the fiscal sustainability of the entire system. That's where we are today. But the cost shift is also a response to the fact that we don't have a uniform fee schedule in the healthcare system in America. What do I mean by that? I mean that unlike most functional markets, healthcare customers are often charged dramatically different prices for exactly the same thing. So suppose you want to get a new car. You go over to Lithia here, maybe you drive up and check out a dealership in Roseburg or maybe one in Eugene. You'll find that the base price of that new car may vary a little bit from dealership to dealership, but only a little bit. If you have one dealer that's charging 10% more for the base price of a new car, they'll go out of business. What if you need a colonoscopy? You're going to pay between $1,500 and over $10,000, depending on where you get it or whether it's for diagnostic or screening purposes. That's a variation of almost 150% for exactly the same thing. Suppose you have three people down here in Ashland walking down the street, arm in arm. One of them's covered by Medicare, one's on Medicaid, one has a Blue Cross policy. They step off the same curb at the same time, they all break their left ankle in exactly the same place, they go to the same orthopedic surgeon and have exactly the same treatment. That physician is going to get paid a whole lot more to treat the person on Blue Cross than the one on Medicare, and a whole lot less to treat the one that's on Medicaid. In what universe does that make any sense? A system that pays less to care for the poor and the elderly than people who are well insured is not only morally and operationally bankrupt, it's fiscally unsustainable as well, for two reasons. First, as I said, the lower reimbursement rates in Medicare and Medicaid are simply shifted to employers through increased premiums, and the cycle repeats. Secondly, as I will hopefully demonstrate in a moment, there is no more money to fund this system. It's not there. It's not there. And that means that whether you are on Medicare or Medicaid or have a good commercial policy, whether you're poor or elderly or belong to a labor union or an employer, Whether you're a hospital or a doctor or a sole practitioner or an FQHC or a community health clinic, we're all in the same boat, and we all are drifting irrevocably towards this fiscal precipice. We need to wake up and see it coming. So where's the money going to come from? If you doubt that statement, it's not going to come from individuals. They can't afford it already. And that's what health insurance is for, right? But even having health insurance is not a guarantee that you can pay the bill. The leading cause of personal bankruptcy in our nation is the inability to pay a medical bill. And the vast majority of people who go bankrupt from medical debt are insured. It's not going to come from the government. It's not going to come from states. We don't have it. We have to operate on a balanced budget, and we're looking at an $11 billion shortfall in the next decade. It's not going to come from the federal government. We're going in the opposite direction. Just look at H.R. 1. But of more concern to me is in increasing part of the health care bill for today is being paid for by borrowing from our kids. That $37 trillion national debt was 18 a decade ago. That's a 92% increase in our debt burden in just a decade, and it's going up and up and up. And the big beautiful bill, oops, I did it. It's going to drive that deficit even higher. And it's not going to come from private sector employers, at least not for much longer. As I mentioned earlier, those prices are simply just cycled around in this cost shifting game. And anyone who believes that the private sector employers will passively and continue to absorb double-digit inflation in their premiums year after year is, I think, dealing with a different reality. So the only way, in my view, the only way we can keep our system from slipping into insolvency is to rethink the business model on which it's built, the financial incentives that drive it, its benefit and eligibility structure. And that starts with having a shared vision of where we want our healthcare system to be at some point in the future, let's say 7 years. The values we want it to reflect, the outcomes that we want it to produce. That may sound daunting, but there is a precedent for this. And how many of you were here, remember the speech that President Kennedy gave in 1962, challenging the nation to go to the moon? I'm definitely dating myself. I got about 4 hands coming up there. Well, it resonates with me, and it's not a perfect analogy, but it's a pretty good analogy, and I'm going to use it because I was there. I'm just going to read you one paragraph. We shall send to the moon, 240,000 miles away, a giant rocket made of new metal alloys, some of which have not yet been invented, capable of standing heat and stresses several times more than have ever been experienced, on an untried mission to an unknown celestial body, and then return it safely to Earth, re-entering the atmosphere at speeds of over 25,000 miles an hour, causing heat half that of the temperature of the sun, and do all this and do it right and do it before the end of the decade. Think about that. What an amazing leap of imagination, which is exactly what it was. Kennedy didn't give us a roadmap. He gave us a destination. And in doing so, he changed the debate from where we want to go to how we get there. And that energized and engaged the entire nation, the imagination, innovation, and passion to go to the moon. And we did it. We did it in less than 7 years. And we did it because we imagined it. This is coming. This is what's ahead, folks. Because the narrative preceded the accomplishment, right? We imagined it, we saw it, and we did it. Together, we can do this. We've done this before in the state of Oregon. I'm looking at Peter here, who was around during the 2011 session. The state was just utterly polarized by a couple of tax measures earlier that year. We had high unemployment. We had a $3.5 billion budget deficit, and we had a divided legislature with the House evenly divided between Republicans and Democrats, 30-30. We managed through that crisis without tearing the state apart, without losing our commitment to one another. And out of that came our coordinated care organizations, which at least in their early years expanded access to about another 380,000 Oregonians and saved money. We are called upon again to do that. We're called upon again to pull ourselves above the divisive partisanship that has become the hallmark of our political discourse in this nation and increasingly here in this state of ours. And I think we're called upon to come together as a people who share a common future and who will all suffer if we don't change the current trajectory of our healthcare system. I think the central question is whether we will continue to operate in the false security of our individual silos, blaming someone else for the circumstances we're in, and collectively accelerating our drift towards the lip of the falls. When it comes to healthcare, we are truly in this together. We're in the same canoe, and we have a choice. We can work together and paddle towards a safe shore, which we have done over and over again in this state, or we can all grab our stakeholder paddles tighter and tighter and work desperately to keep our end of the canoe upstream, driving some sense of security and knowing that those on the other end will go over before we will. We're better than that. I've seen it. We are better than that. But sometimes I feel that we've been allowed ourselves to get captured by this false narrative of extremes. Red states, blue states, left and right, Republicans and Democrats, division and blame. It's a narrative in a space without a center, without a common purpose, and certainly without a common destination. And quite frankly, I don't think anyone really likes it very much, no matter where you find yourself on the political spectrum. It's an uncomfortable place to be, and it's not very productive. It doesn't address the problems that are dividing us in the first place. I think we should remember that partisanship is a choice, and so is civility. We can choose to buy into the negativity, into the blame and the fear, and feed that energy, or we can choose to move beyond it. And what we face today, unlike 1962, what we face today in Oregon is not a challenge of technology. It's a challenge of political will. It's the measure of the depth of our commitment to each other and to our children and to our shared future. And it's a choice to look through the soft eyes of compassion and generosity and see each other as Oregonians and as fellow human beings who are facing a huge crisis that can only be solved if we meet it together. And I believe it's a lot easier than going to the moon. Thank you. Thank you very much.